afternoon, everyone, and welcome to Keto Diet and Brain Tumors, presented by Lori Bumbaco, the Center's Oncology Dietitian, and a special guest today, Denise Potter, who's a registered dietitian specialized in ketogenic metabolic therapy. So she will be our expert today who we're speaking to, and most of the questions regarding a keto diet will be addressed by her. Today's lecture is generally supported by the Team Schlate Foundation. Team Schlate is a 501c3 nonprofit founded in June of 2024 with the goal of increasing glioblastoma brain cancer awareness, supporting warriors in their daily journey, and funding research to find a cure. They're also supporting today's program. Before we get started with the lecture, I would like to share more about the Cancer Wellness Center. The center was founded in 1989, is a nonprofit organization with the mission to help anyone touched by cancer find a way forward. Each year, our free counseling services, support groups, health and nutrition programs serve over 2,000 community members of all ages and backgrounds. People with cancer, family members, friends, and caregivers all come to us to connect and help. Our services, which are both virtual and in person, include education programs like the one today, wellness classes like yoga, meditation, nutrition, and more that provide a holistic approach to healthy living, and support services which include counseling for individuals, families, couples, children, and those bereaved, as well as support groups that are designed to help our participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and the link will be included in the chat. Now, without further ado, I'd like to welcome our presenters.
Thank you so much, Savina, and good afternoon, everyone. Thanks for joining us on this first February Monday of the month. We are excited to be here and joined by our special guest speaker, Denise. I'm going to start things off, and I'm going to speak for maybe 5 minutes because I know why you're all here, and it's not necessarily to hear what I have to share. So I'm going to share my screen. We've combined forces. I have a few slides to just get through, and then we're going to transition to Denise's slides that she so graciously provided and is presenting for us today. So thanks again. So I'm going to share my screen. I was sort of paying attention to Savina, so I apologize. We welcome any comments and questions in the chat, and we'll monitor them. We're going to hopefully also have some opportunities at the end of our presentation today to have some additional Q&A. So let me just get this show started. Okay, so I'm going to start first with just a quick overview about nutrition and cancer, and then a little bit more about really what I advocate for here at the center for most any public presentations that I give. Today we have a really specialized topic, and really, I don't want to call it cutting edge, but it sometimes seems like it is, but we are really going to dive deeper into this metabolic therapy. So I just want to sort of set the stage for what Denise is going to share today as well. So a little bit more about what oncology dietitians do in practice is that we provide personalized guidance in order to help you, no matter where you are on the cancer treatment continuum, really optimize your nutrition status. And there's a lot that nutrition can do. It's best when it's done as close to diagnosis as possible. We are more effective in the preventative and proactive stages of cancer rather than a reactive approach. Nutrition interventions certainly include what we anticipate treatment may result in terms of nutrition impact symptoms. So very often in brain tumors, we do see that treatment can cause nausea and vomiting, as well as constipation and fatigue. So as part of our nutrition intervention, we're going to try to come up with some ideas and strategies to really help to minimize the impact of these in order to optimize your quality of life, but then also how well the treatment is going to work. Medical nutrition therapy, that's unique to what dietitians do. No other practitioners can perform medical nutrition therapy. And we use this systematic process, it's called the nutrition care process, and we address unique nutrition problems. So our medical nutrition therapy is going to be unique to the person. No same nutrition assessments and care plans are the same. We may include really a holistic approach as well. So we know that you're more than just your cancer. You may come to us with some other comorbidities such as high blood sugars or even high blood pressure. We're going to help manage that as well. We're going to prioritize in our nutrition intervention either preventing or reducing the progression towards malnutrition, because malnutrition itself is independently predictive of worse outcomes, as it turns out in oncology. And up to 30% of those who are diagnosed with a brain cancer have become malnourished, according to the research, or at risk for becoming malnourished. And as part of that nutrition intervention, we're also going to optimize body composition in terms of preserving muscle mass. We know that having more muscle mass, even when someone is losing weight, has been shown to improve outcomes, improve quality of life, improve immune function, and improve tolerance to treatment. And for most individuals I work with, those are their goals, especially. So this cancer protective diet, this is really in general. Food and nutrition are a part of treatment. That's how we view my role for someone that I'm working with. And it combines both meeting someone's nutrition needs, which again are unique according to the person, but also the joy that food can bring to our life. And that certainly has to do with quality of life. And food itself is not only pleasure, but it also serves to be connection to our loved ones. And so we do emphasize that as part of the plan if that's on someone's wish list. Now, the American Institute for Cancer Research, they have this is a nonprofit organization, and they have quite the body of evidence, and they encourage these guidelines that I'm going to highlight next. And a way to simplify their message in terms of these guidelines is something called the New American Plate. And this is an image you see here on the screen. It's a practical example of how to build a cancer protective plate. And I'll save that talk for another time. So in the AICR guidelines, the American Institute for Cancer Research, they encourage that individuals who are diagnosed with a cancer maintain a healthy weight with less fatty tissue and more muscle, be physically active, at least 150 minutes weekly, eat a diet rich in whole grains, vegetables, fruits, and beans. And the goal is to try to eat 30 grams of fiber per day. Limit consumption of fast foods, other highly processed foods with extra fats and starches and sugars. Limit consumption of red meat to less than 12 to 18 ounces of cooked red meat per week, and limit processed meat. It's best not to drink alcohol, to limit consumption of sugary beverages, and to not necessarily rely on dietary supplements for cancer protection. There almost always are exceptions. And these, again, are the overall guidelines. We are going to tweak and modify them according to our specific nutrition assessment and intervention. Now, just very quickly, I want to approach a subject that often comes up in practice for me. This is a very popular question that individuals who are diagnosed and their loved ones, they'll ask me this: does sugar feed cancer? We're going to really get into the nuances about this today, and I'm really excited for you all to be able to learn alongside with me. So our current research at this point in time has suggests that we don't have any randomized controlled trials that show that if someone eats more sugar, that they're going to make their cancer worse, or that if they stop consuming sugar, they're going to improve their outcomes. So that doesn't quite read the same, but so we don't see a connection. It's a little bit more involved than that. And the only way that we ultimately can answer this question for you, again, is in a one-on-one consult with a dietitian and within your care team. All of our cells, including our cancer cells, they use glucose as their primary fuel. And glucose comes from more than just sugars. It also comes from other carbohydrates, especially those healthy cancer-fighting ones, like vegetables and fruits, whole grains, and even some of our dairy choices. Now, did you know the body is smart and it will use protein that we eat to make glucose when it needs more? And Denise is going to kind of elaborate on this concept, but I just wanted to introduce it for you now to start thinking about. Research suggests that the relationship between sugar and cancer is a complicated one. So it may turn out to be that insulin levels and growth factors like IGF-1 have a more potent influence on cell growth, and that may be more of the issue as it relates to sugar and sugar-feeding cancer. It might be more about insulin. So it may not necessarily be sugar by itself, but what too much sugar can do to our body systems that's more concerning for cancer. So what do experts recommend then about sugar and carbohydrates for someone who's been diagnosed? We do recommend that we limit all sources of added sugars. Again, that's a kind of a broad statement, but one-on-one with an individual dietitian consult can help you get to the bottom of that answer. Complex carbohydrates are some of the healthiest choices that we can consume in an overall diet pattern. They contain a package of nutrients as well as some other substances that can help to regulate and modulate inflammation and also control our insulin levels. And we have seen that through research as well. A ketogenic diet is not just a low sugar diet. It's not even just a low carb diet. You're going to learn it's a metabolic therapy, and that's what Denise is going to share with her expertise today. Now, there is more than just one ketogenic diet. There's actually several versions of it, and it is a medically tailored plan that requires dietitian support to ensure that someone is keto adapted. And that this may also, at the same time, the dietitian is going to help to reduce the risk for any complications in pursuing a medically tailored plan. Now, there are promising studies in using ketogenic diets for glioblastoma. And so that's why we're here today. I think it's really exciting that we have Denise alongside to help give you some really helpful, important information today. Now, there is an overwhelming amount of nutrition advice online. It's on social media. It may even be coming from your friends, family members, and it may be well-intentioned, but it may not necessarily be appropriate for your situation. A lot of people do turn to me with a lot of confusion and they get contradicting information. You've come to the right place, especially if you have questions about the keto diet. You're going to learn a lot today. Our presentation is a high-level review of a medically tailored diet. If you were diagnosed with any cancer type, it is advised that you discuss with your healthcare team about any diet intervention that you are contemplating. We just want to know. Now, no matter what type of cancer you or your loved one is diagnosed with, we do know that when you work with a registered dietitian, the nutrition care that you receive can do ultimately a lot of good things for yourself or your loved one. And there's a lot of strategies across the continuum of your care that may help optimize your outcomes and especially, again, improve that quality of life. So thank you for joining us. Thank you for feeling a desire to learn more in the hopes of empowering yourself. With all this being said, I'm going to switch the screen over to Denise. I'm going to advance the slides for her, hopefully in a good enough manner. And she's going to take the floor. So thanks again, everyone.
Thank you so much, Lori. Thanks for setting that up so well. And it's funny, the more you said, the more I'm like, yeah, keto does that, keto does that. Keto is so much more like the recommendations than it is unlike the recommendations, I think is the important thing to remember as we go through this. So yeah, I'll let you move on ahead. These are just my disclosures. You can take a look at later if you want, nothing too important there. As a generality, and I put this question on here and, no one really knows, right? What causes cancer? Is it a genetic disease? Is it a metabolic disease? And that's the question. And it's kind of which one comes first? Is it a genetic alteration that happens and then it's passed on during cell division? Or is it because of a defect in the cellular respiration and then that's causing the cancer? And because of this, and you can advance the slide, just like which comes first, chicken or the egg? we don't always know, but we know it's there. But the big picture, and like I said, there's so much you can read, and I didn't want to spend lots and lots of time on this, but because I wanted to summarize, and you can go to the next slide. The summary here is cancer cells highly prefer glucose for energy, and Lori already said, glucose is what all of our cells need. Like I had one person, it was a long time ago, but they I'm trying to get my glucose down to 0. I'm like, no, that means you're dead. You don't try to get your glucose to 0, but we want it regulated and lower because if you're familiar with a PET scan is tracking where glucose goes. And it's highly attracted to cancer cells. So the things that light up on a PET scan, they're lighting up because extra glucose was attracted there. That's what lights up. So it's simply that most cancer cells prefer that, and most of them can't as easily use ketones for energy. And that's what we want to do with a ketogenic therapy. So if we have less glucose available for the cancer to use for growth and replication, it may reduce the tumor burden and reduce the proliferation of the tumor. So on a ketogenic therapy, I'll take a minute here just to broadly explain that if you're not familiar. We're taking the body from the state of where you would usually use glucose for energy all the time and having your body almost, we're faking it out into starvation. Okay. You're not starving. But what we're trying to do, and this has nothing to do with the slide right now, we're trying to make it burn fat for energy versus burning carbs for energy. So it's almost like you have an electric vehicle, a hybrid vehicle, and you're going back and forth between gas, electric, gas, electric. So we can use largely ketones, even though there's always going to be some glucose, we can switch over to be in ketosis using largely ketones for fuel. And that's what we're trying to do. That's why it's a metabolic therapy. We're changing the metabolism of the body to get that. And it's a little tricky to keep you in that metabolic state, people there. So moving on to this slide. So this pleiotropic, so many mechanisms associated with KMT. And if I just say KMT, I mean ketogenic metabolic therapy. It's just an abbreviation we use, either that or keto diet. And so what happens here is, and this is a summary from a research article, when you start the ketogenic diet, what we'll see is ketones increase, partly because of the low carbohydrate intake, also because of a high fat intake. You can't, like she said, it's not just cutting carbs. Just cutting carbs by itself doesn't put everybody into ketosis. What that does, looking down the middle here at the green boxes, we increase brain fuel by manner of ketones. The brain loves ketones for energy. We decrease reactive oxygen species and inflammation. We increase HDAC inhibition. We increase fatty acid oxidation. We decrease glycolytic flux, and we decrease that insulin secretion, which she is saying, hey, we've got lots of studies already that say decreased insulin is good for cancer. So we're doing several things here that are beneficial. What we're seeing and any study that I've ever seen that measures quality of life in cancer and keto always shows an improvement in quality of life. We see a direct tumor impact. We do see, again, so much of this parallels what she said. I love it. I love it. You set me up like that. I feel like set up, take the swing. And then body composition with the ketogenic therapy, well done. We see preserved muscle mass and decreased fat mass when people do want to lose weight. Some people do not want to lose weight, and that's fine. And they don't if we don't want them to. But we're preserving lean muscle mass, and that's super important for outcomes. And then we see decreased tumor growth. So on the end page is we improve patient outcomes and hopefully decrease tumor viability. So in general research, and I'll use this slide just to say one more thing. It goes back to when we talked about glucose levels, and we want lower carbohydrate, which means levelized glucose. And I don't have the slide for this in this presentation, but there are some studies in glioblastomas very specifically that say people with lower glucose levels have longer life expectancies with glioblastomas. I mean, that in itself is enough to say, wow, we need to follow some guidelines that at least lower our blood sugars, right? If not, decrease them as keto decreases them a lot, not to unsafe levels, but it lowers them a lot. So you can go ahead and advance to the next slide. This is a nice pictorial view of many preclinical studies, preclinical meaning mouse and rat and rodent models, basically, animal models of studies. So keto has been studied in a lot of animal models. And then in the middle here, it says, what's the tumor effect on these? And the green, and I know this is too small to read, so I'm just going to tell you a little bit about it. I know this is not an ideal slide, but the green is the anti-tumor effect. So you can see largely we see that. We see the yellow, some of these saying, hey, we're not seeing a benefit either way. The orange in that slide is the pro-tumor effect. So there are some cases where we might not want to do keto. And this is in the preclinical, only in the rodent models. We haven't seen pro-tumor effects in human models as of yet. So, but we do want to be cautious that could happen. We don't know everything. This is very early on in the research. On the right-hand side, you see clinical studies, many studies on many, many different types of cancer. And if you go on and advance to the next slide, I've done here, this is just a slide we put together in our practice just to give a visual of, wow, here are some of the ways it's been researched. So if it has 1 star next to it, it's only case studies and animal studies. If it has 2 stars filled in, it's clinical uncontrolled studies. So that's on humans, but uncontrolled. And then clinical studies that are controlled would be the ones with 3 stars. And this slide's year or two old. It's not super old though. So it's pretty up to date on as far as that. Well, we weren't trying to hit every kind of cancer, but I think it just kind of helps to say, what do we have so far? And then moving forward, in this article, this is a review. It is a few years older, but they again kind of summarize that we've in the underlined in red here. You can see that we've 72% of those preclinical studies, those rodent models are saying, hey, we're seeing evidence of benefit 72% of the time. If this was a medication, if this was a drug, I promise you, if it was 72% to the positive and only 8% to the negative, like that part where it was anti, that drug is going to get a lot of attention and get, possibly approved because those are really good numbers in a drug study. When it's keto, it really freaks people out to have any, issue. And I always, and we all, if you watch any television, you see any drug commercials, you see there are numerous side effects to our medications. And I'm certainly not anti-medication by any stretch, but we take, we have to take the good and the bad when we do a treatment. So if there are risks with keto, again, we have to put them all in perspective of how we, what treatments we want. Anyway, but at the bottom line here, they say the probability of achieving an anti-tumor effect seems greater than that of causing serious side effects when offering ketogenic diets to cancer patients. Okay, so our probability and what I've seen in real life and in the research is the probability is very good for many cancers. So it's really specifically glioblastoma. Okay, so this is the first, just a couple things, very specific to glios. So this retrospective case series was published in 2020. There were several case reports published before that, which then that were positive, that then led people to say, wow, we need to start compiling evidence. So this is 12 people with CNS tumors, central nervous system tumors. They found that keto was feasible, that people were able to maintain ketosis. They improved their symptoms, they improved their metabolic markers, so they lost weight, their insulin levels went down, their diabetes got better, things like that. And they showed early signs of disease control. So that was great. So okay, that was in 2020. Then the next one is an RCT. Okay, so that's a randomized control trial. And that's when they did here keto plus intermittent fasting during radiation with a recurrent glioma. So, and this, what we find with these early studies and research, honestly, in the last 5 years, I've been involved in research. The whole previous 25, 30 years of being a dietitian, I was not doing research. So I didn't really understand all this, that you have to first establish safety. I mean, which it makes perfect sense, right? But it wasn't on my purview because I did things that already were established, right? So first they have to establish safety. So they did that. They said, okay, this approach is safe. We're inducing ketosis. Again, we're lowering glucose. In this one, they didn't show improvement in 6-month survival. I will say that, and I cannot remember how many weeks this is. Sometimes these studies are in 12 and 16 weeks. With a ketogenic therapy for a brain tumor, I really, if it's showing any benefit, I do not want people to stop. And I hate to say, keto being a life sentence, it might be a varying level of ketosis, but if they were eating an unhealthy diet before, we can't go back to that. Okay. Go ahead and advance to the next slide there. And I have to move sorry, my apologies. Telling me I have a new computer and have to adjust. Okay, so this safety and feasibility trial published in 2025, and I'm kind of really proud of this because this LJ Amaral, who's the first author, is a registered dietitian, Lori. I didn't know if you knew that. LJ is really cool, and it's exciting to have a registered dietitian as first author on a paper. So this is newly diagnosed glios with a 16-week 3-to-1 ketogenic diet. Now, you'll hear me talk a little bit about ratios. I'll take a second here to explain it. 3-to-1 means 3 parts fat, 3 grams fat, 1 gram protein and carbs. It means over 80% fat. You hear people say macros, you hear people say ratios. They mean the same thing. It's just a matter of what they are. So we can think it. So generally in a ketogenic diet, we've got to get well over 70% fat into that 80-85% range. So this is like over 80% fat, just so you know. Doesn't mean your plate has 80% fat like by the plate. It means by the calories on your plate. And that's different than having, 3/4 of your plate be butter. anyway, so they proved again, it was safe, it was feasible. People were able to do this because sometimes there's an argument that people say, well, no one can do this. This is too hard. It can't be done. It can be done. We see it done every day, but I won't say it's easy. And this study produced encouraging survival and once again, improved quality of life. Can go ahead and move up. And then this publication in 2024, this has 1 million authors. Well, maybe exaggeration. This has a lot of authors. This is a clinical research framework proposal where they said, hey, if we're going to do keto for glioblastomas and gliomas, we need to have something solid to stand on and everybody do it the same way, right? So we're not having all these researchers do it. You do it one way, I do it another way. So they outlined the KMT strategy. We want to target glucose and glutamine. And if anybody's read anything by Dr. Seafried, who's very big in the space, he's also an author on this paper. We want to target those things to lower glucose, potentially lower glutamine. And then we're using GKI guided diets. Now, GKI, you'll see a couple times on here. GKI means glucose ketone index. So when we measure your glucose, we measure your ketones, we do a little math, we just literally just divide them, but they have to be in the same, the same number, same millimoles. Anyway, we divide them and that's the GKI. So it's nothing fancy. How are your glucose in relation to your ketones? All right. That's all GKI is. It's just an extrapolated number from data that everybody's gathering anyway. So they also suggest caloric restriction within reason. Again, and all of this, the great thing is, in this paper, they're recommending, as Lori said, individualized care and practice, because what works for one person, what's an appropriate diet and ratio and amount of fat or fasting or not for one person is not the same for someone else. So they wrote this framework to say you still have to individualize it. Okay, now I'll let you go ahead, Lori. And then lastly, this is exciting. So they're recruiting for a phase 2 multi-site randomized control trial to get this many people, 170 people. Thankfully, glials are rare enough that they need to go wide. And I forget if it's 12 sites, quite a few sites that they're recruiting from. And they want to see whether an 18-week dietitian guided, we appreciate that, KMT can improve overall survival compared to the standard anti-cancer diet alongside standard of care. So anytime I'm implementing keto, it's alongside standard of care usually, unless someone has decided something else. I am not an advocate of ketogenic therapy standalone. Okay. I mean, I think that's a very scary situation because it enhances, in some of the earlier mouse models going back, it enhances improvements when there's radiation, and keto enhances when there's radiation and chemo, more so than by itself. And so just know that when we're saying when I'm saying I recommend this therapy, I'm saying alongside other treatments. Okay. And then in this review, I'm going to make sure I'm saying it properly. Yeah. So a review of all these studies, a lot going back, all these studies says, most published studies saying this is effective. It has positive impacts on patient survival. Most of them are showing that survival improved over typical prognosis of the usual standard of care with temozolomide specifically. Okay, and you can move on from here. Next slide. As we look at the different things that we would monitor when someone's on a ketogenic therapy, biochemical, body composition, quality of life, cachexia, if they're not able to eat, and weight loss, what we find, moving on, is that go to the next slide, that it is safe and tolerable. Again, all these things had to be established before we can even have anyone pay any attention to using this as a treatment modality. So taking now, theory and the studies, what do we do? What if someone wants to do a ketogenic therapy? Let me tell you a few details about how that starts to look. And I need to, excuse me, I moved you guys there. Okay, so the first thing we're going to do, if we're going in my company, we're going to work with somebody, we do a full thorough intake on them. We want to know we do the same thing Lori would do, okay? We want to know what you're eating, what you're allergic to, what meds you're on, what supplements you're taking, all the things. We want to look at your labs. We're going to rule out any contraindications. There really aren't very many reasons not to do keto, but there are a few. So if someone's, there are some different medical conditions where we may say, whoa, keto is not appropriate. A lot of the things that when we use keto for epilepsy, the things that we have to rule out for children, those things are ruled out. Like you would know if you had GLUT1 deficiency and you're 50 years old. I mean, there are just things like that we aren't looking for typically in adults because they're childhood conditions and genetic conditions that are discovered way earlier. And we evaluate nutritional status because there could be someone that's in such poor nutritional status that we just need calories in them and we don't care where they come from, and it's not appropriate to start keto for people who just they can't eat. You can't restrict their diet when they can't eat. We're also looking at their social support system. That's very big. You'll hear me mention that a few times because it's really hard to do this on an island. It's not impossible. I've certainly had people do it, but it's difficult. So we really hope we can enlist any supports that people have. All right, the education phase. So the first broader part is education, but then looking at preparation. What do we do? We're going to evaluate risk benefit with people. Now, a lot of times they've done that before they get to me, but they're going to evaluate, whether this is safe, whether it's a good idea or not. We're going to start eliminating any extraneous sugars from medications, from supplements, chewables, liquids, things like that. And then the obvious, we're going to take out, let's get rid of all the sugar, extraneous sugar from your diet. Just boom, step one, no more sugar. We need to obtain supplies. Now, there aren't a bunch of supplies, but we tend to use a glucose ketone meter. The common one we use, and I don't work for them, but the most common one used and the best one is the Keto Mojo. There really isn't any good competition, to tell you the truth, or I would tell you the competition names. There's Optimum Neo if you're in Europe, but the Optimum Neo in the US you can't use for ketones. So we use that. People might do also continuous glucose monitor, which is very useful. And continuous ketone monitors are available in some countries. They're not available here unless you've kind of got a friend in another country that can ship them to you. Okay, you cannot order them to be shipped to the US as of now. There are other companies in the US that will eventually have these continuous ketone monitors, and that's going to blow everything up as far as research goes when we get those. That's another story. But if any of you are familiar with I actually have one on right now, but if you're familiar with the CGMs, those monitors that people that have diabetes have, you can get the same thing for ketones. That's what I'm talking about. Anyway, so the next step we do is we try to figure out their plan. And that's after spending, about an hour with people, we try to figure out, how do you think? How do you, ask people if they think like an artist or do you think like an engineer? Because if you think like an artist, I'm not going to give you this very strict diet. I'm going to give you something that allows you to be more flowy and flexible. But if you think like an engineer and you want things, or you're an accountant and you want things to be very set and strict, and that's how your brain works, then I'm going to give you this precision keto, if that makes sense. And sometimes we'll start people with a precision keto or a weighed, measured, specific thing to get them going. And then we'll move them to something a little more flexible once they get into good ketosis. When we're talking about glioblastomas here, we don't have time, and you guys know this, we don't have time to spend several weeks, months getting into ketosis. We want you in relatively quickly. We want to maximize the ketones within people's tolerance. And I'll do a quicker initiation for people in these situations when possible, and maybe even some fasting because of some of the research. In general, I love to start keto relatively slowly so we don't have these side effects, and I can avoid all your initial side effects, no keto flu if we want to, but sometimes I'm scared to death when people are given a diagnosis that is so short, then we're gonna blast in. Okay, management and follow-up care. We're monitoring lab work. In general, people are undergoing cancer therapy. They're having way more labs than I would ever need. And so it's real easy if we need to add a lab on to do that. We're managing side effects, if any. And also, of course, there are side effects of some of their medications and treatments. We're going to supplement very cautiously. Our practice doesn't give any supplements that are to treat cancer supplements, but I might say you really need to take a multivitamin, or wow, you're not getting any calcium, things like that. We certainly do, but we don't give out, and this is just my practice, we don't give out a bunch of extra supplements trying to treat the cancer with supplements. And then again, we're always adjusting the therapy to optimize our outcomes. We're trying to get the ketones up and the glucose down in very simple terms. So when do we use a ketogenic therapy? I mean, you might say, oh, for anybody that has a glio, but here's number one, do they want to do it? Because we've talked to many, many well-meaning family members that absolutely want the diet more than the patient does. And so they have to want it. Number one, first and foremost, if they don't want to do it, then we're not going to do it. They have to have, or we want them to have, family support. Again, very difficult to do if no one around you is supportive. Financial ability, I put that in there, but I also like to argue it a little bit, because sometimes people say keto's so expensive. And I dare say there are some studies where people have said, no, it's not. They've proven it with some data to show that. And when you start knocking out all these extraneous things you buy and the snack foods, and we're not buying keto this and keto that, I guarantee you, yes, keto brownies are very expensive. I don't want you to eat them anyway. So you're not going to have a larger expense. You're buying meats, complex carbohydrates. So you're buying vegetables, meats, and fats. I mean, that's what we're purchasing. We're very few processed foods here. And then again, when to use, if we have no contraindications, no, if you're in liver failure, I'm not putting you on keto, or if you're in renal failure, I'm not putting you on keto. I mean, there are some reasons we would not use the diet. So how do we choose this? Again, we're looking kind of through our list of people's abilities, and can they cook? Some people can't cook. They don't feel well enough. So what are we going to do now? And I'll talk about that in one of my case studies, what we can do if someone can't cook. Do they have family support? Do they have doctor support? In all honesty, here's what I have transitioned to myself as a provider, and this is just, again, per opinion. I used to say, ask your doctor if you can, and I don't know, Lori, how y'all feel about this, but I'm going to say it because this is the way I practice, okay? I'm not representing the cancer center. I'm just telling you what I do in my own business. I used to say, please ask your doctor if it's okay if you do keto. Guess how many people came back with friction from their doctor? And I realized, partly after I was kind of mad at the doctor sometimes, but then I realized, okay, when I tell you to ask your doctor if it's okay, that's putting a liability on your doctor. And that's saying, for this treatment that is very new, that's still being tested, we're learning about it, that I want them to put their stamp of approval on it. So you're asking them to do something that even on a licensure issue is really hard for them. Although there's a lot of data, they use medications in cases. They can cross over with medications and say, oh, it worked over here, I think we'll use it over here. And that's okay. But they're not always comfortable with that with a dietary therapy. So I tell people to just notify your doctor, let them know. Like Lori said, let me know what you're doing, please. Because then when you come into the hospital or you come into clinic and you're doing things that are very different, and then people are just digging around trying to understand. And if you just tell them what you're doing, and also hopefully we want people to work with a practitioner who knows keto, preferably a registered dietitian. I actually have one physician on my team, but basically we want somebody who knows what they're doing. And if you tell your team, yes, I'm working with someone who, and I'm not trying to just advertise myself. I'm just saying there are many people doing this. I'm working with someone who knows what they're doing and I'm being monitored, then they can relax a little. But again, I hesitate to ask for their stamp of approval. I think that's too much pressure on their medical license. What are their goals? We need to know what they're doing, because some people are like, I just want to feel better. Some people, I'm going to kill the cancer right now. I mean, everybody has a different layer of what their goals are and what they're willing to do in their commitment level. What is the route of the food? And you might think, obviously, we're going to eat it, but a lot of people have an enteral option, which means maybe a G tube, an NG tube, a gastrostomy tube in their stomach, and an NG tube through their nose, or even a tube that goes down into their jejunum, into their intestines. So you might see different options. We can even do parenteral nutrition. That means IV nutrition. That's I've never done it in cancer therapy, to tell you the truth. I'm just telling you keto can be done that way, but we've never done it with cancer in my practice. And also we're considering people's protein and calorie needs. So as we're figuring out what diet to put you on, what plan, we're very conscious of your protein, because that's one thing Lori's probably all over that. Like, you've got to give these people protein. And we do within limits. We start cautiously, we make sure we meet needs with protein, and then we go up and adjust as needed. Okay. Education, I'm not going to read through all these. This is just to show you. Here's a general list of all the things we cover as we educate people. It usually takes 3 or 4 visits before I really feel like I've covered everything. We've kind of gone over everything and people are getting comfortable. It really, the first 3 to 4 weeks when someone starts a ketogenic therapy, it's such a shift on what, for most people, it's such a shift from what they used to do. When someone starts telling you, hey, put more butter on that, and you're just saying, I've been waiting all my life for someone to tell me to put more butter on that. And, use more olive oil and use more of this. And it's very against most of what we learned and we're trained. And so again, this is a medical treatment, and we're trying to change a metabolism. And so it also takes you can understand in your brain, but to accept it and get there, it's not a snap thing. It takes some time, it takes some support. So we're going over, like I said, all kinds of details, which we can talk about some of these in Q&A if you guys have specific questions about things. So here are the different types of ketogenic therapies. So I'm just going to give you a bird's eye view of the 5 different diets. So the first one on the left, upper left, classic ketogenic diet. So when you hear someone say, wow, my kid was on the keto diet for epilepsy 20 years ago, he was probably on a 4-to-1 ketogenic diet. That's what we did when we first started, and back in the 2000s when I started, we put almost everybody on this very strict 90% fat diet. Some of them were nice enough to let them go down to a little bit lower. That 3-to-1 made it a little bit easier. Really tough. Everything's weighed down to the gram, down to the 10th of a gram. Okay, very strict. Go straight down from that, modified Atkins. Modified Atkins diet is just simply saying, hey, you know what? Let's eat 10 or 20 grams of carb. You can do it, eat lots of fat, 10 or 20 grams of carb. And this is where you hear people saying, all I eat's bacon and eggs and steak. And you could do that and only eat 10 or 20 grams of carb. If you do it right, you might have ketones on modified Atkins diet. But if you don't moderate your protein and increase your fat enough, you won't have ketones. So it's an option for some cases, but I don't use it in cancer treatment. Going across the bottom, this LGIT, low glycemic index treatment. That was figured out by a friend of mine, Heidi Pfeiffer, a great dietitian in Boston. And they were trying to find something for teenagers. Like, oh my gosh, these kids, they have epilepsy, they're in their teens, but this diet up here on the left-hand corner is not working for them. No way. So they made something more flexible and allowed a little more carbohydrate, and yet still got some good benefit for people with epilepsy. So we use pieces of all of this, and when we get over to the modified keto. But go over to the upper right, look at MCT oil keto. MCT oil keto is a low-carb ketogenic diet with upwards of 50% of the fat being one certain type of oil, which is medium chain triglyceride oil. That's extracted from coconut oil, and that helps you get better ketones. You can eat a lot more carbs if you use a lot of MCT oil. But I promise you, a lot of people eating 50% of their calories from MCT oil, one, it's a little bit gross, and two, you might be running to the bathroom a lot. Let's just say that. You can work your way up on that. And anyway, I was going to tell a joke, but sometimes it falls flat because not everybody watches Princess Bride. So anyway, so go on back with me to the middle. Go to the next slide. This modified keto diet. This is what we've done here is pulled in all of these diets together. Okay, we put them all together and we said, hey, if I use the best things of here, if I use the ratio method, thinking of it in terms of the ratios, getting the percents of fat right, I pull in MCT oil. we pull in the strategy of LGIT is like use whole foods and use vegetables, so we pull in that, and then the carb restriction of the modified Atkins. So they're all included here. And this diet can either be done, and you can go to the next slide because it's just an addition here. It can be done by grams, or it can be done by measuring cups. So I can tell you a cup of vegetables, 4 ounces of meat, 3 tablespoons of oil, or I can tell you 100 grams of this, 50 grams of that, etc. So we can calculate it either way, and we give sample meals and try to set people up. So, but this is modified diet just gives us latitude to say we can express it. And then if we wanted to go above this 2-to-1 or 1-to-1 ratio, that's like 70 to almost 80% fat in there. If I want to go higher, then I can go to a 2.5-to-1 or a 3-to-1. I can go a little higher. But when you see, just take your mind back. You don't need to take the slides back to that 4-to-1 diet. And you see this in some of the cancer research. A 4-to-1 diet, an adult cannot get enough protein on that unless you're 25 years old and you run 10 miles a day and you need 3,500 calories. Okay. Then I can get you enough protein. But let's just say, as a general rule, you can't do it on a 4-to-1. So please don't try. We can wiggle people on a 3-to-1. One of my case studies has a 3-to-1. So, okay, go ahead and fast forward here. So other things that we do, things to think about prior to chemo, we might do some fasting, and this fasting is really individualized. We're going to talk about that on another slide. Pressed pulse therapy is incorporating things like, and that's kind of in that other clinical recommendation too. That's where we're saying, hey, let's push hard on the ratio. Let's do some fasting, maybe use some metformin to lower blood sugar, maybe some exogenous ketones, which means outside the body, which means drink the ketones. So let's put all these things together. We might do a strict keto and restrict calories for a period of time. Even if someone's at a good weight, maybe for a short period of time to try to make the chemo more effective, we might restrict calories and then loosen the calories up after when they finish with chemo, but not go off keto. Do we loosen this ratio in calories between treatments? I would loosen the calories, but personally, and then maybe the ratio slightly, but to me, it's a matter of going, if you can see me up here, I would be like here or going up with the ratio. I'm not going to say, oh, well, you can go off keto between treatments. No. I wouldn't do that based on what we've seen so far. Okay, so moving forward, talk about optimization. So as we're working with people, we want to adjust the macronutrients, so their protein, their fat, their carb, or their ratio. It's got to work for them. I might think you need a 3-to-1 diet. You might need 85% fat, and you say, absolutely no way. I'm not going to do that. And so, we have to be realistic. We'll look at the calories. We'll look at whether or not you need vitamins. Often it's nice to have a low level of vitamin supplementation, just kind of cover the bases. Maybe we use these extra ketones that you drink. They're very expensive. I'm not sold on them that everybody should use them. I'm certainly also not against them. Okay. I'm still riding the fence on those. But we just don't have tons of research on them, but there's some. Intermittent fasting is for some people, not for everybody. I have a whole slide on that next. And then again, personalized. I think the next slide is, intermittent fasting. So on the right-hand side, should everybody fast? Absolutely not. On the right-hand side, what it does for us, it increases ketones. It improves that glucose ketone index because it lowers your glucose and raises the ketones. It increases cell autophagy. So the cells are recycling and getting rid of the bad parts of the cells and killing, bad cells. So we want that fat. That's shown outside of keto to be beneficial. And again, we know it decreases glucose, but on the left-hand side, if someone's malnourished, absolutely not. We're trying to get good nutrition in them. We're not going to restrict them. If they have deficiencies already, we may not want to do intermittent fasting. If they already just can't eat enough, if they barely can eat enough all day, I'm certainly not going to say, well, you should fast, 16 hours a day and only eat within an 8-hour window. That's a super common way people do it. But absolutely not if you're having a hard time getting your calories in. So, we weigh all this out. And if someone has cachexia, we probably wouldn't have put them on keto anyway because if they're just having, terrible weight loss and wasting, then they're probably not appropriate for keto. And then this is the last slide before our case studies. And I love doing case studies, but I want to talk just a little bit more about measuring ketones and glucose. I mentioned already I kind of went ahead of the slide, I guess, but the keto mojo meter being one of them. There's also just for fair time, there's the Precision Extra, which is the oldest one I've used many years ago. Still works, but the Mojo has increased sensors, so it is I feel like a superior meter. And it also does this calculation of the glucose ketone index. So we're pretty happy with that. But also what's going to come next though is the CGM and CKM, these continuous monitors. We're really close to having, the CKM available in the US. And then you're not going to want to do that all the time because it's expensive, but you're going to want to do it if you're doing ketogenic therapy. It might be something you do at the beginning of therapy, and then maybe you do it every couple months. You wear the monitor for 2 weeks, really see how things are going, and make sure that overall your numbers are good. And it helps you track trends in a way that we just can't do when we test 1, 2, or even 3 times a day. You just don't see those trends as well as we do with the continuous monitors. So really excited for those to be more available. We've only had a few people in our practice use them so far because they're just difficult to get, and they run about, like for me to get one right now, I have them shipped to Germany. It's about $100 each, just for reference in case anybody's wondering. Okay, go ahead. I'm going to tell you about a couple of patients that we worked with at AKT. And this first lady came in with a glioma, 64 years old. She didn't have any other significant medical history. Of note, she is a healthcare provider herself, a physician, a certain type of physician. She's given us permission to, anonymously tell her story. She came in at a really good weight. She's 5'3", 110. She's a real trim lady. So she didn't want to lose any weight. And again, people come in saying, I don't know if I can do keto. I can't lose weight. And she's one of those. And it's entirely fine. She didn't lose any weight. End of the story. She was on standard of care treatment. So she's on the Temodor chemo. This Vimpat is a seizure medicine. She had 1 seizure at diagnosis. Cepra, Zofran, for nausea, and then she had a tumor resection, and then she put herself on a ketogenic therapy. She came in already largely doing it, and we find that more and more where people come into us saying, okay, I'm doing this, but I don't know if I'm doing it right, or I need more help, and they come in already, well on their way toward ketosis or in low ketosis. Okay, go ahead and advance. So supplement wise, she took a multivitamin. She needed some vitamin C. A lot of times I'll supplement with D because so many people have a low vitamin D. I'm almost always recommending additional D, but her multi had enough D and her numbers were good, so we let that go. She's taking some calcium and this potassium. We would use Morton light salt, which might sound crazy, but it's a salt blend of potassium and sodium. And so we use that and just have people sprinkle it on their food for a potassium supplement. She utilized MCT oil within the diet. And when we started her labs were all perfect. No lab issues. And you can see the diet we started her on, this 3-to-1, 1,700 calories, very, very low carbohydrate, 12 grams of carb. Now, people a lot of times step down to that. 12 grams of carb is a scary number if you haven't done keto before. Not everybody has to go that low, and not everybody goes to a 3-to-1. Okay, again, 3-to-1 being that's about the highest I can get people and get her. We're getting her barely enough protein with this. I can see Lori's probably like on the protein there, but she's getting adequate, but not extra. Okay. So her ketones were really great. So this 3.4 on ketones, just for reference with adults, if I get adults 1 to 3, that's not bad. With cancer patients, I'm trying to get them even higher. If they can be 3, 4, 5, I'm good with that. 3.4 is fabulous. Glucose average of 82, also fabulous. So this GKI number, the goal is to be below 2 when you average these numbers out. Okay, hers was 1. I mean, so that is the standard goal, but that it is really hard to achieve that 1. And it's also, it freaks people out. They think, oh no, I can't get my GKI to 1. It's not going to work. That's not necessarily true. I'll show you in the next case study, okay? But and even the doctors, Dr. Seafried would tell you that, oh, everybody doesn't have to get there. We're just trying. You know, we don't have enough evidence to say that's what we have to have. If we go back to where when they came up with GKI, they based that number on some animal studies and some case studies, okay? So it's based on very scant research just saying we think this is a good idea, you know, they're so it's just know that it's a goal, but it's not proven yet that that's necessary, so we don't want people feeling like failures when they don't hit that goal. Okay, so she's tracking her meals on Chronometer, which is an app that you can get to track put your food on. Okay, it's a nice system. So we looked at all her foods and I'm, you know, without great detail, like, whoa, you're lacking in this, this, and this. We either need to get you more of these food items that go, you know, that cover these bases, or we may need a supplement. We're always trying to do it with food over a supplement. Okay, always food is best. So move forward from there. At her 4-year outcomes, and this is just like 2 months ago or 3 months ago, she emailed me and said, hey, I just had my 4-year scan, okay? And I'm not working with her actively anymore. Every now and then she pops up and asks me some questions, okay? 4 years, she's still resolved. She has no evidence of tumor. Her weight is still stable. Her quality of life is great. She did have low carnitine, which is one of the labs we tested. We can supplement, but what I'd rather do is give her more beef and more lamb. And they did that, and that resolved that low lab. And her cholesterol is high, and that happens on keto. That's always, I'm sure we have Q&A questions about that. And um, she had a coronary artery calcium scan, and it showed no evidence of plaque. And so we're marching on and not worrying about that. And honestly, if you want to get me started, let's talk about high cholesterol versus a brain tumor, and ask me which one wins. Okay. So yeah, so that's her. And she's, you know, it's really, I always love hearing from her to hear how she's doing. And then go on to the next lady. This woman, and this is actually, so the first one is not a real picture, okay? That was a stock photo. She wants to be anonymous. This lady shared her name. We're calling her Bev. It's not her name, but she shared her photos with me and said it was okay to share. So this is her grandson, Jackson. This is her motivation in life. Okay, so this woman came in with a grade 4 glio. She already had a resection. She had Lynch syndrome, so she had already some likelihood to have some cancers. Endometrial cancer, had a foot neuroma, so lots going on in her history. Her BMI was 26. Below 25 is desirable. So she wanted to lose a little weight. So we've got some weight to work with there. She had a very typical diet. She didn't eat a bunch of sugar and a bunch of sweets, but she didn't eat necessarily a super healthy diet either. Lactose intolerant, that's no big deal. And then her labs were all fine that we checked beforehand. She was a retired nurse. She had a great family. Her family is the one that contacted us and said, hey, you know, we need help for our mom. One of her daughters-in-law was a dietitian, all kinds of support. They had money to afford treatment, you know, care and things. Her husband's awesome, but he does not cook. And she's getting very tired. And one, you know, thing I didn't catch as early as I should have is that the family was more motivated than the patient. It was easy to say this now in hindsight, but it becomes very clear. So what diet should we initiate? I've already told you, hey, I'm going to do this modified keto because I'm pulling in everything on that. So I did modified keto, and I'm trying to initiate her. Go ahead into the next slide. Trying to initiate her over, at worst case scenario, 1 meal a week. I'd really rather do 1 meal every couple days, like breakfast for 2 days, and then breakfast and lunch for 2 days, and then breakfast, lunch, and dinner. That's what I'd like to do. But after about a month, we're still not fully on keto. And she just looks at me. Well, she didn't look at me. This is so long ago. I was literally, some people did Zoom and some people were doing phone. So this is on the phone. And she said, I just don't feel as invested as everybody wants me to be. And I could hear it in her voice that she was tired and she just didn't know if she wanted to do this or not. Like, is this worth it or not? And I thought, oh my gosh, you know, so we had basically, I'll say, a come to Jesus meeting and just like, and, you know, what do you want to do? What do you want to do? Go to the next slide. So we talked about a few things. We talked about KMT being a medical treatment. Like, this isn't I mean, we call it a diet. It is a diet, but this is a medical treatment. So I talked to her about, like, if you do this, if you choose to move on, I want you to look at it just like your chemo. You go get your chemo, you go get your radiation. This is a level of care that is to be considered the same as those things. So we talked about that, and then I said, you decide, you get back to me. I want you to think about it and get back to me and decide. So we gave her a little time, and she did say yes, obviously, because here we are. So we decided to get someone to prepare her meals because that was a big hardship. We didn't get a chef. We didn't get somebody fancy. We just got they found a local lady who was staying home with her kids who could cook. Okay. It didn't have to be anything fancy. Well, 36 weeks. So what's that? 8, 9 months or whatever, 8 months outcomes. Her glioblastoma is resolved. There's no evidence of tumor at that point, which you could have that without keto, right? Her weight has come down nicely. That's resolved. Her fatigue's improved. Her ketones are only 1 to 2 at best. We weren't even checking glucose, so I don't even have a GKI on this person because she's one of my earliest GBM patients. It took us 4 weeks to get her on keto. That was insanely slow for what I wanted to do. Okay. I wanted to do it in 4 days, but that's not what worked. And so that's not what we did. She was having scans every 6 weeks with no evidence of tumor. And personally, I think they were scanning her a little bit often, but they don't ask the dietitian how often do scans. Anyway, so go to the next slide. This is at 5 years. This is what's more impressive. 36 weeks, big deal. At 5 years, she still was doing great. Overweight resolved. She had a 20-pound weight loss, so her BMI is really nice. She's feeling good. She's improved, her fatigue is gone or mostly gone. And this is what she said to me, that a day without Jackson was like a day without sunshine. I'm gonna cry. So this is just one of the stories. Of course, we're only going to tell, I'm putting on, these are the wins, right? Not everybody has this type of win, being, very realistic, but some do. And it's very amazing when you can walk with someone through this. So I'll stop with that because I'll just start babbling on. That's really the end as far as that. I've left a million references on here. In all honesty, those are, I don't know if you guys are sending out the slides, but those are from a bigger presentation where we talk about all kinds of cancers. And then this is just our contact information at AKT. So yeah, well, that was plenty long. I hope I didn't go too far over here. So, okay, I will stop. Leave room for questions.
Thank you, Denise. That was amazing.
Yeah, absolutely. We did have a couple of questions live, and then I wanted to ask a couple of the pre-submitted questions, but we'll start with the ones live. You did mention the slides. We do have a request for those, so we'll connect and share with people after. You mentioned the MCT oil. Is that added uncooked as a topping, or is that something that someone would cook with when they are using the?
It's better to do uncooked. It has a low smoke point. So we don't really, if you added it at the end of something you were it was hot on the stove and you wanted to stir it in, that's fine. But otherwise, I would use it in salad dressings. Anymore, I kind of have people do a little shot sometimes of some unsweetened almond milk and some MCT oil. And it's a whole other thing about starting it gradually. Okay. You'll get a stomach ache. I have people start with like half a teaspoon to half a tablespoon once or twice a day. Okay. And you work up, but it'll upset your stomach if you start quickly. Anyway, but you make a little shot, maybe some heavy cream for part of your fat and the MCT for part of your fat and the almond milk, which is pretty neutral on as far as barely any carbs and barely any protein in it. So it just kind of works as a carrier. And you can whisk that up or blend it up and just drink that. And then you've added some fat to your meal without having to put lots and lots of butter and cream and oils on your food. So I like to it's a little fat shot on the side.
Thank you so much. I like the description of a fat chat.
Mm-hmm.
I know this is a program about the ketogenic diet, and that is what we're focused on. We did have one of the pre-submitted questions of somebody who's wondering of kind of the difference or the benefits between keto versus the Mediterranean diet. And I know you talked about the high cholesterol, but this person particularly is concerned about high cholesterol. So talk a little bit about that.
Yeah. So, I mean, Mediterranean diet is, I mean, I've heard people kind of discuss and argue that like there's not even a set, like what does that exactly mean? Like it means different things to different people. But when you say, oh wow, let's eat healthy fish and meat and vegetables and olive oil, well, that sounds a lot like keto, except we're moderating the amount. Like we're trying to do, I mean, keto, I don't always say Mediterranean keto, but a lot of the things we're trying to get people to do are leaning along that lines. A Mediterranean diet's not going to put you into ketosis, and without intention. And so you can do Mediterranean keto, but just by itself, the actions, those mechanisms that keto starts reducing inflammation and decrease ROS, and the things that keto does, don't happen on a Mediterranean diet. Some of those things you'll have advantage of, maybe lower glucose levels, but not lower to the point of keto, lowered inflammation, not to the point of keto. So it's definitely a good way to eat. Or someone said, well, I'm thinking about eating paleo, or here's an idea. And Lori would tell you this, cut out all your processed foods. She already said that, right? A lot of anything that she said, like I just did, but just wanted to put a little bit on steroids, with keto and with some specifics, because those intents, the intents, the intent of eating a very healthy whole food diet is still there. And if cholesterol is an issue, like, again, we weigh it against what we're fighting against. And cholesterol is one, just keep this in mind. And there's so much information. If you want to get a good information on cholesterol, there's a couple people. David Diamond is one person who's talking. This is about keto in general and cholesterol, okay? Not about cancer specific, but that's fine. David Diamond and David Feldman are people who are doing some research known in the space. And then on Metabolic Mind, which is a website, and it's a nonprofit formed for mental health for keto. There are a million videos. Brett Scher is the person who does all the interviews on all their videos. He's a cardiologist. And he addresses this in many videos, so if you go to the Metabolic Mind and to their YouTube, they address lipids again and again and again. Like almost too much. You're like, oh, well, which one do you want me to watch? But just pick a couple. But just saying that we're not seeing, even when we see cholesterol go up, so far we're not seeing an increase in heart disease. Okay, that's one thing. I always say we don't know everything yet, and if anybody tells you they do, they're a liar. We certainly don't know all the things, but I'll tell you that I've never taken anybody off keto for cholesterol. Okay, we look at it, we try to adjust the diet, we try to improve their numbers, and then we also look at it as them as a whole person. It's one number. I promise you that many of the medications, and if you remember, go to any commercial on TV about meds and all the list of side effects, and yet the doctor gives you that medication and we take it, right? So yes, there's a side effect. A certain amount of people will have an increased cholesterol. We're not seeing yet increased heart attacks and those things. And even if we were, it would just be one in many of a list if I was just doing it on a drug commercial on TV. So yeah, I hope that's enough on that.
Can I ask a follow-up question? From the non-keto dietitian? Is there a transient rise in cholesterol when someone's starting, and then when they keto adapt? Does that?
Yeah, thank you. So if you check cholesterol when someone just started keto and you recheck it, or they just lost 15 pounds and you recheck it, you're going to get a different number than if you let it ride. So definitely there are some studies that show that over the course of a year, you have kind of an increase and then it settles back down in a year. Okay, so it is, writing it out. And again, it's one number, and what we don't see, if you just look at total cholesterol, you got your good and your bad. Most people are familiar with HDL being the good cholesterol. Well, someone's cholesterol might go from their HDL was 40 and now it's 90. That made their cholesterol go from 200 to 240 or 250. But it was good cholesterol making it go up. So then when you look at their ratio, and they calculate that a lot of times on your labs, your cholesterol to HDL ratio, that very often is good with a high total cholesterol because of that HDL. And and there's other ways to take it deeper. It's a bigger conversation, but yeah, so it's really super general and honestly kind of ignorant to just say, oh, your cholesterol went up, don't do keto, that's bad. Are you kidding me? Liver enzymes go up all the time. The doctor doesn't take people off meds because we might say that med's very important. I know it's having a little impact on your liver, but it's doing what we want it to do. So we're gonna let that ride and monitor. Okay. So I don't want to claim it's never a concern, but we have to not throw the baby out with the bathwater.
Thank you so much. You mentioned the 3-to-1 diet where it's 1,700 calories, 12 carbs, 40 grams of protein, 80% fat. What does that look like? Can you kind of help us visualize that?
Um, I can. You know what? So we can. Oh, you can't do it. Let's see.
So it's like a serving of carbohydrate per day.
Yeah. Well, I was just trying to think of a quick visual. I can't
Meal.
pull up
Yeah.
on the fly a picture, especially since if I hadn't just changed my computer from PC to Apple, I could. But what it looks like is like in general, I'll say it would be like, let's say she had 3 ounces of meat. So let's say a hamburger patty, a serving of broccoli, a little side salad, and then um 2 or 3 tablespoons of olive oil and maybe even a little more butter on the broccoli. Like super, super generalized, okay? But so it's a moderate meat portion of a small vegetable, whole vegetable, and maybe another because the greens, we could have some spinach or some lettuce on the side, and that becomes a carrier for the fats. And then again, but we have to have enough fat on there, and it's always more fat than one would think. It has to be a measured amount because most people won't put enough fat on without being told how much. Does that help? I said, I wish I could pull a picture super quick, but I just can't in the time we have and with my new technology.
Yeah, absolutely. Very helpful. Thank you so much. And we do have a couple people with the pre-submitted questions and some that are in the chat who seem to be doing some keto on their own, maybe possibly working with some family members who are supporting them or friends, but sort of unsure of best way to approach. So looking for resources. And for those of you who are on the call and who may be watching after on Zoom the recording, that is the reason we are actually working with Denise today. So I will share her information in the follow-up email. That way you could reach out to connect with her team privately for that consultation because there are, as she mentioned, a lot of indications or a lot of considerations that the team will take prior to deciding what is the best for your specific needs. So we will share that. One of the questions in here is, are there any indications of the keto diet being helpful to other cancer types outside of the brain tumors?
Yeah, absolutely. There are, and Lori and I talked just the other day, like, hey, there is some very specifically in the mouse models of ovarian cancer. This is a negative, okay? They said, hey, this might be worse. In mouse models of some renal cancers or kidney cancers, there are concerns that might be worse. And then you said also what, AML?
AML.
AML might be worse. Those are the only three that I've ever heard of that we're worried that it might be worse. So beyond that, there are studies, and I know the slides are, it's teeny, but that study, there are slides on, the one of them is very small, and then you've got the one of the body. But there are studies in all different kinds of cancers, and we've worked with people with a lot of different, we work with people with prostate cancer, breast cancer. One woman with breast cancer, the doctors are like, I can't believe how well you're doing. No one does this well. And I said, well, did you tell them you're on keto? And she's like, no, I was afraid to say it. And I'm like, you're supposed to tell them you're on keto. Like, that's the first thing I tell people. You got to let the doctors know. But she's afraid because the doctor's telling her to eat ice cream. Okay. And so, people, it's a weird thing going on. Anyway, so we work with people with a lot of different cancers and just under the balance here that in research so far, most of the cells are less receptive to ketones as an energy source. In the studies we have, most of them don't, they may adapt to it over time, but they're not as receptive to ketones. So most of the energy is coming from ketones over glucose. And then there's somewhere else I was going with that. Anyway, so yes, we'll work with, outside of those three that we have concerns, we'll work with anything, because we know that, said, we're using PET scans, we're trying to figure out where the glucose is going, and we can reduce that glucose substantially. So a ketogenic diet glucose looks like this, just little bumps. And when you're on a regular carbohydrate, rich diet, your blood sugar goes up and down and up and down, and that's never thought to be necessarily bad. But if we can limit those peaks, then we're hopefully limiting a fuel source for the tumor.
Thank you so much. This has been a very informative lecture. We really appreciate your time here with us today, Denise. We are at time, so I do want to be mindful of everyone's time today. We will share, again, as I mentioned, Denise's contact information. You're welcome to connect with her privately. As always, Lori is a resource here at the center, but as she mentioned, that is not her specialty and background in. So we do encourage for that specialized care to do seek a dietitian specialized as well. So again, thank you everyone for your time today. We will share the recording as well. So if you do need to reference back to anything, you can watch it again later.
Okay, thank you. Thanks for having me.
Thanks so much, Denise.